Ready for coming. It's great to have everyone come out. It's really nice to talk about a topic that is very much our business, and this is preventing sudden cardiac death, which is a significant risk factor for many of our patients. And tonight we'll get to particularly the role of the Wearable Cardioverter Defibrillator, also known as the LifeVest. And we're all somewhat familiar with the LifeVest. It seems like it should be very straightforward in its function, and it is. There's also a lot of subtleties and nuances to managing patients with LifeVest, and we'll talk about some of those particular features here tonight. So a few disclosures. Disclaimer, this is really broad informational. Your use of the LifeVest is up to you, so your own discretion is advised. Outline for tonight, we'll talk first of all about sudden cardiac death and implantable defibrillators and when we use them and what they do. We'll make our way to the wearable cardioverter defibrillator, how it works and feasibility, use of the LifeVest in particular situations, particularly post-MI, post-revascularization, whether that is stenting or bypass surgery, during CHF optimization, and then finally particularly guidelines for use and insurance coverage. So sudden cardiac death, by definition, is an event that occurs unexpectedly. It's sudden, without warning. Death usually follows within minutes, and the whole event is cardiac in nature. 350,000 cases of sudden cardiac death in the United States per year. That's about 40 victims per hour. So you can think in the hour we spend here, there'll be approximately 40 sudden cardiac death events in our country. About a 20% survival incidence for the events that we're talking about. So this is a major leading cause of death in the United States, and here you can see it's about the same as stroke and lung cancer combined in terms of its mortality, and much more significant than other conditions that we actually probably fear more, such as breast cancer or AIDS. Causes of sudden cardiac death, why do people die suddenly? In the vast majority, 80 to 90%, it's due to ventricular tachyarrhythmias, either ventricular tachycardia or ventricular fibrillation, where the heart rate in the pumping chambers is just too fast to support life. 10 to 20% are from other causes, and we can think of acute MI, myocardial infarction, causing pump chamber. The muscle is just too infarcted to pump effectively. And then also bradycardia or asystole. There just is no electrical activity, and that can be a minor but important cause of sudden cardiac death. So just a review of the arrhythmias that can cause sudden cardiac death: ventricular tachycardia in 62%, also ventricular fibrillation, torsades, which is a form of ventricular tachycardia, and then importantly, people dying of bradyarrhythmias, the heart just going too slow, and that can be a cause of sudden cardiac death that we need to be aware of. But the vast majority, as we can appreciate, are from heart rhythms that are just too fast in the main pumping chambers of the heart. So we can ask ourselves, why do sudden cardiac death victims have ventricular tachyarrhythmias? And the primary cause, overwhelmingly, is coronary artery disease, which is accountable for 80% of those events in the United States. And that can in fact be the first evidence of coronary artery disease in both men and women, particularly in women. And we've seen that, where the patient's presentation for coronary disease is an arrhythmic event. And the presentations for arrhythmia, the heart cath is done and it shows culprit coronary artery disease, which is really the underlying cause. And the first goal for treating the arrhythmic event is in fact a revascularization strategy. And then we wonder about protecting patients from a recurrent arrhythmic event in the context of revascularization. And we'll see that the LifeVest is important there. So we all know this scenario. We have coronary artery disease, causes ischemia, it causes infarction, causes scar. Scar and ischemia induces electrical instability in the heart, forms foci to support malignant ventricular arrhythmias, and those either at the time of ischemia or acute infarction or later in the presence of scar, we get that fast ventricular arrhythmia, which is a manifestation of that coronary disease, and suddenly you have sudden cardiac death. You were alive and well, and now you are on the floor hoping to survive. So a very significant problem that we have to protect our patients against really at all costs if their risk is in fact substantial. So how do we treat sudden cardiac death? Obviously the first thing we want to do is address coronary disease, and that is revascularization, medication, addressing risk factors for coronary disease, whether that's hypertension, diabetes, smoking, stress, inflammatory states, diet, exercise. We promote recovery of a depressed ejection fraction, which is a major risk factor for sudden cardiac death, with optimal medical therapy. That therapy also promoting electrical quiescence, if it's beta blockers or an antiarrhythmic drug. And then having done all that, we still say this person could be at significant risk, and so we want to protect them from breakthrough ventricular tachyarrhythmias, either with an implantable cardioverter defibrillator, and that has historically always been the transvenous device, where the device sits subcutaneously, the lead goes through your veins into your heart, or more recently by Boston Scientific, the subcutaneous ICD, where the whole thing is very superficial under your skin, nothing's actually going through your blood vessels into your heart, and we've of course implanted numerous of both devices. And then finally, as protection, there is the Wearable Cardioverter Defibrillator, or LifeVest, and we'll see what role that has in patients who deserve ICD protection, but for a variety of reasons are not yet eligible for an implantable device. That's the role of the LifeVest. It's a bridge to something, either a bridge to recovery where no defibrillator is indicated, or a bridge to implantation of a permanent device, and that'll become clear. So we say, are we protecting patients at risk from sudden cardiac death? So we said about 300,000 cases in the United States per year. And here we can see that the vast majority of those events occur in the general population who have some coronary disease, some scar, maybe recognized, maybe unrecognized. Ejection fraction is relatively preserved. They don't meet criteria for ICD of any kind. In fact, the vast majority of events, hundreds of thousands of sudden cardiac death events, will be in that population. As the coronary disease gets severe and your ejection fraction starts to drop, then your percent risk for having an event goes up dramatically, and we start to get into criteria for implantable defibrillators. But we have to appreciate that only a minority of the overall sudden cardiac death events in the country is going to be in that very high risk population. They're truly at risk, but by protecting that cohort of the population, we are only protecting a minority of patients who actually have the arrhythmic event, which tells us we absolutely have to cover that segment of the population with defibrillator protection, because their risk is exceedingly high, recognizing that we're going to miss the vast majority of people. And a huge question in cardiology is, how do we predict who those individuals are going to be, and how do we mitigate the risk when the number of people in that cohort is so large? So our guidelines for ICD implantation, just to simplify, primary prophylaxis device is when your ejection fraction is reliably less than 35%, and that's whether your cardiomyopathy is ischemic or non-ischemic. And that is despite revascularization, it stays low on optimal medical therapy for at least 3 months, or for over 40 days post-MI. Then you qualify for a primary prophylaxis ICD. You've never had an arrhythmia, but you're at high risk, so we give you defibrillator protection. So while you're waiting to meet these waiting periods and fulfill that criteria, how do you protect someone from the ongoing risk during those periods? And we'll see that the Wearable Cardioverter Defibrillator provides opportunity to give protection during those waiting periods. And then also a secondary prophylaxis. So you've had a malignant ventricular arrhythmia. There is no obvious reversible cause to that arrhythmia, so you deserve defibrillator protection, and we can implant defibrillators without a particular waiting period. So kind of those two broad categories. This slide, this iceberg, represents all the people in the United States who will have a sudden cardiac death event this year, 350,000. All of those below water will have sudden cardiac death without meeting ICD implant criteria. So the guidelines don't even offer them protection. The iceberg above the water is everybody who does qualify for an ICD. The little circle, red space on the top, is the number of people in that indicated population who actually receive ICD protection. So we recognize, first of all, that the guidelines fail the majority of patients who will actually have a sudden cardiac death event. And for those patients who do meet guideline criteria for an ICD, in fact, we fail to implant also the vast majority of those, protecting only 20%. So in general, the population is underprotected and the significant life-threatening events continue to occur. So again, ICD strategies, historically, it's always been the transvenous ICD. You know, the device traditionally over the left pectoral muscle, lead goes through the vein into the heart. That's traditional. For the last couple of years, Boston Scientific has offered us the subcutaneous ICD, where it's all outside the thoracic cavity, still providing ICD protection like that. Patients who are eligible do not need a pacing requirement. Their QRS is narrow, so their chance of needing an upgrade to CRT therapy is small. Are candidates for the subcutaneous ICD, and we offer it to those patients who do meet criteria. And as you've all experienced, we've implanted numerous of both devices in our population. So there's what the x-rays look like for the transvenous, for the subcutaneous. The arrows point to the shock electrode. So if they actually needed therapy, the shock would be between the pulse generator and this thick portion of the lead, which is in the right ventricle for the transvenous ICD, and subcutaneous anterior to the sternum in the subcutaneous ICD population. So both of those sandwiching the myocardium in different ways to provide you defibrillator protection that you need. So what are situations then that preclude ICD implantation where there may be a role for the LifeVest? So we've already mentioned waiting periods. Trials for primary prophylaxis ICDs required 3 months of ongoing pathology before the implant of the ICD, and CMS has kind of adopted those guidelines where they will not cover the ICD unless you have 3 months of a sustained indication. And that's post-PCI, when your ejection fraction continues to be less than 35, post-CABG, when the ejection fraction does not recover, and when you have a new diagnosis of low EF that's going to be treated with medical therapy, it has to stay low on good therapy for at least 3 months to qualify. And those guidelines are, you know, embedded in our culture now, but they're somewhat artificial in their origin. And we have to think that during those periods, the person continues to be at high risk for a sudden cardiac death event and really does deserve protection, and that's where the LifeVest can have a special role. If the ejection fraction recovers, you take it back, send it back to the company. If the ejection fraction does not recover, the LifeVest is exchanged for an implantable device. So again, waiting periods post myocardial infarction. So if you have an infarct, if your setting is acute MI, it has to be at least 40 days. And that's the result of 2 trials completed in 2004 and 2009, which showed no benefit to an implantable defibrillator in that early period. And why? Because in those populations, a certain number of people, having just had a myocardial infarction, in fact, died of pump failure. The myocardium failed in the setting of a heart attack, such that the ICD did not have a mortality benefit in the entire cohort. So we're left to wonder if there's a subset of patients in that cohort who would have survived, did not have pump failure, and would have survived if you could protect them from just the arrhythmic events. And we'll see that there's truth to that and validity in providing the LifeVest to protect patients in that scenario as well, to help those who will survive to the time when they're eligible for the ICD implant. And then other medical conditions. So you can have a depressed ejection fraction, you're awaiting your revascularization or your CABG, you have to wait for whatever reason. There's another illness perhaps, they want to medically optimize you. You can't, even in hospital, have the wearable cardioverter defibrillator on to protect you in that high-risk waiting period. Again, history of sudden cardiac death when you're awaiting PCI or CABG, so you've had the arrhythmia, you already meet indications, but we're planning a major procedure for you, so it's prudent to wait till after that to do your implant, so why not protect upstream while you're in fact waiting for that event. VT storm, we'd like to have some control of the arrhythmia before we implant a defibrillator so the person just doesn't get relentless shocks. You can use the wearable defibrillator where the patient can press buttons to abort unnecessary shocks if they'd like to. New York Heart Association Heart Association Class 4 heart failure. When you're in that classification, you need to improve to at least Class 3 to meet ICD indication, so you could protect patients while they're awaiting medical optimization to improve to where they would be candidates for the implantable device. ICDs are contraindicated when your medical prognosis for other reasons is less than a year. Say it's terminal cancer. Those patients may want to be protected from an arrhythmic event during that time when they don't qualify for the ICD, and the wearable defibrillator can play a role in that setting. And also, if you're waiting for heart transplant, you're at high risk, but you're very high on the list to go for transplant. It's expected in weeks or months. You know, the wearable cardioverter defibrillator, rather than implanting a device that's going to then get removed at the time of the heart transplant. And then also practical considerations, scheduling, lab or OR personnel availability. You know, you can use a wearable defibrillator to bridge. And then personal needs. You know, we find people who need defibrillators, but they want to travel. They have a wedding to attend. It's like a scheduling issue. So you can offer them the wearable defibrillator as a bridge to a time when it's convenient for them to undergo their procedure. So this is the LifeVest. We've all seen them. This is the schematic. 2 electrodes for monitoring the rhythm. The vest sits snugly as it should. You have self-gelling defibrillation electrodes, so if the device thinks it's going to need to shock you, it will release gel to improve contact and the effectiveness of the shock. The patient has a response button that he can or she can press to abort shocks. So the device thinks it wants to shock you and you're like, I don't need a shock. You can press the button to inhibit that. Or if you have symptoms, you're like, I feel my heart racing, what is that? You can press the response button and get telemetry that'll then report to the website. You can download, look at it, help symptom rhythm correlation, diagnose a variety of rhythms. And then, of course, the battery pack is capable of shock function. So we'll see some higher level monitoring and interactive features available in the LifeVest that are not available in implanted ICDs because the concern for battery longevity is less. You can recharge this. Once you implant a device, there's no recharging. You need that device to last as long as possible. So some flexibility in the capability of the battery allows the LifeVest to have some unique features like the patient interactions and the voice alerts. So this is basically how it goes. You're in normal rhythm, you develop a ventricular tachyarrhythmia, the device detects the arrhythmia, it begins a vibration alert, then a siren alert begins, the siren alert gets louder, the patient gets an audible prompt, so the LifeVest speaks to you, it says an electrical shock is possible, the gel is released